Good afternoon, ladies and gentlemen. First, let me introduce myself. I'm Phimchanok Yeunchon from Phramongkutgao Hospital. There are numerous factors to consider when discussing multi-ligament knee injuries. Given the limited time today, we will focus specifically on the definitive treatment of the chronic multi-ligament knee injuries. First of all, proper alignment of the entire limb plays a crucial role in effectively managing the chronic ligamentous injuries. To abdominal knee alignment can place excessive stress on either medial or lateral structures, ultimately increasing the risk of the reconstruction failure. So now we will dive into management strategies for the chronic multi-ligament knee injury. Let's start with the KD2, which involve the bicruciate injuries, one of the rare types of the knee injuries, with an incidence rate of just 1 to 12%. During the physical examination, special attention should be given to the PLC. If the PLC is overlooked, it significantly increases the risk of ACL and PCL reconstruction failure. If the physical examination doesn't provide a clear diagnosis, the stress film should be used to assess the PLC injury. Now, the question is, should we operative single bundle or double bundle technique? Based on the current literature, the single bundle technique is the most favored, widely used for the ACL reconstruction. For the PCL reconstruction, biomechanically studies suggest that the double bundle is better replicate the knee neutral kinematics and help reduce the posterior translation. However, the clinical outcome between two approaches means quite similar. In conclusion, both ACL and PCL can be successfully reconstructed with either single or double bundle technique, depending on a specific case and surgeon preference. Then, which ligament should be fixed first? From the literature review, there's 3 approaches: ACL first, PCL first, and 2 simultaneously. Fixing the PCL first is often recommended because if the ACL fixed first, there is an increased risk of posterior tibial subluxation. On the other hand, some studies suggest that fixing ACL first can lead to better functional outcome and more favorable stress radial graft. The third approach is the both grafts are tensioned simultaneously. This method helps avoid the potential problem of the posterior tibial translation after ACL fixation, as the shake weight effect stabilizes the knee, resulting in better posterior stability and improve the functional outcome. However, despite this different strategy, the optimal sequence remains a topic ongoing debate, with no clear consensus in the literature. Let's move on to KD3M, which involves ACL, PCL, and the MCL. During the physical examination, special attention should be given to the MCL. Stress film should be evaluated to extend injury. The question is, which MCL reconstruction should be most effective? The 2 main categories is anatomic and non-anatomic reconstruction. The anatomic reconstruction, the LAPAR technique, is often used. Studies show that this technique effectively restores the valgus stability and improves the knee function. The non-anatomic reconstruction offers several options, include single bundle techniques, triangular vectors technique, and the superficial MCL reconstruction and the posterior medial capsule imbrication. Biomechanically, studies have shown that this approach can improve valgus stability and similar degrees to the LAPAR technique. Additionally, this eliminates the need of the additional POL graft that reduce risk of the tunnel collision. Moreover, there's non-anatomic technique that tibial attachment still remain. This can reduce the risk of the tunnel collision also. At a 2015 systematic review in J. Atro found that all these techniques resulted in all side-to-side valgus film widening less than approximately 3 millimeters. However, these options are no clear consensus that which one is better. Let's move on to the KD3L, which ACL, PCL, and LCL was involved. The physical examination is crucial. The key test is the diol test to evaluate the PLC. If the physical examination is inconclusive, the stress radiograph can also be used to evaluate PLC if the stress film is more than 12 millimeters. So, which PLC reconstruction technique should we perform? There is two main approach: fibula-based and tibial fibula-based technique. The tibial fibula-based technique, the Laprade method, offer more anatomic reconstruction. However, it's require more extensive approach that technically carries an increase of the tibial tunnel collisions. In contrast, the fibula-based technique is less invasive, shorter of time, and fewer grafts used. Comparative studies have shown that both Arcio, Laprade, and Larson equally effective in restore knee stability. A 2020 systematic review in AJSM concluded that there is insufficient evidence to favor fibula-based or tibial fibula-based is over each another. Now let's discuss the KD4. All ligament is included. There is global instability requiring complex reconstruction to restore knee stability. One of the critical decisions in these structures is whether to perform single-stage or the stage procedure. Historically, single-stage reconstruction carry a higher risk of the arthrofibrosis, but however, more recent studies such as those published in AJSM 2019 show that a single-stage reconstruction can offer comparable outcome with a significantly improved recovery with immediately post-operative rehabilitation. Systematic review from BJM 2023 and E4 2020 conclude that there is still insufficient evidence to clearly determine which technique is superior. The early post-operative rehabilitation is the single most important factor to influence outcome. Good results have been reported both single and staged and two-stage procedure. The ultimate decision is depend on the resources wealth and surgeon preference and ability. That said, current trends supported by the study from Issachaus 2017 favor acute single-stage reconstruction for the most cases. However, the surgeons with limited experience or available surgical time, stage reconstruction may be considered. The E4 2020 also recommend a stage approach, beginning with the repair or reconstruction of the extra structure, followed by the cruciate reconstruction 6 to 8 weeks later. Then, if the single-stage reconstruction with all 4 ligaments, one important question is which graft should be fixed first because we got 4 ligaments. The current concept, according to the ABJS 2020 recommendation, PCL should be first fixed to restore the central pivot and prevent the posterior tibial displacement. The ACL should follow in extension to ensure the full knee extension, followed by the PLC in 60 and knees and medial at last. Another challenge in 4 ligaments reconstruction is the risk of the tunnel convergence. Reconstruction, multiple tunnels at the distal femur and proximal tibia increase chance of the tunnel collision because of limited bone mass in this area. Tunnel convergence can be compromised graft stability, fixation device, and lead to potential graft failure. So, how do we avoid this issue? The femoral tunnel, we can reduce the collision by carefully positioning the tunnel. Superficial MCL tunnel should be aimed 40 degrees proximally and 40 degrees anteriorly to avoid the interference with the PCL. Also with the POL, should be aimed 20 proximally and 20 degrees anteriorly to minimize right to convergence with the PCL. Additionally, both LCL and Popliteus tunnel, the blue and the light blue one, should be direct 35 degrees and 40 degrees anteriorly to reduce the risk with the ACL convergence. Tibial tunnel. We use the same principle. Regardingly, the biomechanically study AJSM 2016, when both PCL and POL tunnel aim directly to the Gertie tubercle, the convergence PCL and POL is high rate at 67 degrees, as you see at the highlight in yellow and the PCL in the green. To reduce this, POL tunnel should be positioning 15 millimeters medially to the Gertie tubercle, as you see in the red one. Additionally, the PCL tunnel on the green on the right picture can be convergent with the superficial MCL on the pink one. We can avoid this by angling the superficial MCL tunnel 30 degrees distally to be the light blue one to reduce the interference with the PCL tunnel on the green. Other technique to avoid tunnel collision it's essential to use anatomic landmark to ensure the proper tunnel placement. Using the spatial aiming jigs such as outside-in technique can help plan tunnel trajectory, while fluoroscope can be used before reaming to confirm the correct alignment to avoid the coexisting tunnels. When dealing with the multi-ligament injuries, it's essential to thoroughly assess all affected structures. Missing even one single component can have a catastrophic consequence for the patient's outcome. The complete physical examination is vital, but if the physical examination is inconclusive, the stress film can provide a valuable confirmation. Additionally, addressing the malalignment is critical. If left uncorrected, can lead to reconstruction failure and poor long-term outcome. Surgical management must be personalized each patient. This includes considering the surgeon's experience, available resources, and graft choices. There is no one-size-fits-all approach. Tailoring the surgery in the individual is the key of the success. Finally, with a high index suspicions and meticulous preoperative planning for evaluate, patient can have the best chance of avoiding complication and having successful surgical outcome. Thank you.